Hey guys, so today I am going to do a PowerPoint and lecture over the ethics in pharmacy along with the laws in pharmacy. This is chapter two, kind of. Um, I always used to do it out of our old book in chapter two. It was chapter two. In our new book, it's kind of dispersed throughout. They kind of talk about the laws. And so I'm just kind of going to put it all together. And this is really important. I kind of wish that we had been able to do this in person, but it is a fundamental thing we got to start with at the beginning of the school year. And so we got to do it. So you're just going to have to learn it. And then hopefully you can memorize. It's just a lot of memorization. Um, and we will do more practice with it as we get closer to the actual test because there's a lot of laws on like pharmacy law on the certification test. So I'm going to present the PowerPoint here. Bear with me for a second. Okay, so hopefully you guys can see my screen here. And I am going to play this here. Okay. All right, so the laws. Key terms, you need to know all of them. There's a bunch of them here. And we'll go through each one and talk about them. And hopefully you can remember them after this if you pay attention. Okay, so I put all these, actually, let me go back. I put these all, oh, they're not. They should have all been in order, but unfortunately they're not on this one. I think this is an old PowerPoint, but I'll fix it. It should start with the 1906 Pure Food and Drug Act. So, but I think on this PowerPoint as we go through, they're all in order, hopefully. Okay, so the 1906 Pure Food and Drug Act was enacted to stop the sale of inaccurately labeled drugs. Oh, by the way, anything in red is kind of like really important to know for this specific law. Okay, continue. So manufacturers were required at this time to provide truthful information on the label before a drug was sold and prove the drug's effectiveness or efficacy. Why do you think this is so important? Well, it's important because at the time, and even before this, there would be people who could sell anything and say, well, it cures cancer or it helps with this drug, this ailment or this or that. And so they weren't really able to, prove the efficacy, which means like that it works, its effectiveness. They couldn't prove that, and so they could just sell whatever. So this act or this law was passed so that it stopped um, manufacturers from selling things that were not efficacious or didn't work. It also stopped the sale of inaccurately labeled drugs. So if they were labeled inaccurately, it also helped with that. Okay, so then the 1914 Harrison Narcotics Act. This was actually on the test last year. My past students in the last few years have told me that this has been on there. I know for sure it was on there this past year. It was enacted to curb recreational use of opium. So we talked about opium in chapter one, but opium was a really big deal back then because before this, it wasn't really regulated. You know, they had founded it. And, you know, before this time, before they figured out opium was like a really helpful drug in taking away pain because it's a narcotic, they didn't have anything. So it was really a big deal to find something that would actually help with pain. The problem with narcotics, though, are just the absolute addictiveness of them. And it's not something that, addiction is not something you can really control once you're addicted to it. It's very difficult to get off depending on the type of drug that you're on. And so, we're seeing this now with a heroin epidemic. Heroin is a opioid. It's a synthetic opioid. Um, so way back then, they had founded the poppy plant and were using that to create, things like morphine and opium. So they put this act in place because it made sure that you had to have a prescription to get it. That was a huge deal. You couldn't just get it just because you paid someone for it. I know, right? Like they literally used to be able to get drugs, no problem, or this kind of drug, no problem without a prescription. But that ended that. It required records for prescriptions, and importation and distribution were restricted. So of course, there's probably still a black market like there is today for drugs, but it helped to curb that because it was so out of hand back then. 1938 Food, Drug, and Cosmetic Act was enacted because the 1906 law was not worded strictly enough and did not include cosmetics. All addictive substances had to be labeled warning, may be habit forming. That was a big deal as well, to have a label that, was warning people of the addictiveness of a drug. It required drug companies to include directions to consumers regarding the use of a drug and package inserts. So it gave more information to patients about the drug that they're taking. Defined the exact labeling for products and defined misbranding and adulteration as illegal, and provided the legal status for the Food and Drug Administration. That's another big deal, the FDA. So that they could basically take people to court, take manufacturers to court, and actually, be a regulator over these things, a national regulator, and actually be able to do something about it. Because if they weren't they didn't have that legal status, they weren't legally able to, put these laws, practice these laws, and shut manufacturers down if they weren't doing these things. So it was important. 1951 Durham Humphrey Amendment required a label on prescription drugs to say, caution, federal law prohibits dispensing without a prescription. Required a doctor's order and supervision for certain drugs. It made the initial distinction between legend drugs and OTC drugs. That's a very important line there. They put that in the last test as well. And that's how they worded it, was it made the distinction between legend and over-the-counter drugs. Remember that legend drugs are by prescription only, and OTC medications are non-prescription drugs. Remember, they're over-the-counter. You don't have to have a prescription to buy them. So something like Advil, Motrin, Tylenol, Benadryl, all of those things you can buy without a prescription. But it was important to distinguish the two, and say, okay, we think people can handle these drugs without a prescription. They can, follow directions and take them. It's a relatively safe drug. And then these drugs, need to be prescription only drugs. They need to be, regulated by a doctor, because it could have health consequences on patients if they don't have a doctor, helping them take those drugs. So the 1962 Kefauver-Harris Amendments were enacted in an attempt to ensure the safety and effectiveness of all new drugs on the market. So the burden was put on manufacturers to ensure good manufacturing practice. So that's when they were like, hey, you've got to follow these rules to manufacture drugs safely and effectively. And I'll tell you, it's a really good thing that we have this in the United States, because they're very strict on what drugs can come on the market, what's in those drugs, where they come from, regulating what's in the drugs, because other places like China, for instance, a lot of those drugs are not, and the manufacturers there are not regulated. So you really don't know what you're getting over there. Even if you're making a drug and you have, say, 5 different kinds of compounds to put in one drug, one of the compounds may be something completely different. It may not even work or be effective. And so it doesn't actually make the drug that you're trying to make. So you'd have to worry about that in countries like China. But here in America, we have such strict laws on drugs, and it's a good thing because it protects us. Also, this in the United States, it prevented the sale of thalidomide because children in Europe were born with birth defects after the mothers had used it during pregnancy. And you can see these pictures of these children with deformed limbs and things like that because of that thalidomide. And that was included in this as well. Okay, so 1970 Comprehensive Drug Abuse and Drug Abuse Prevention and Control Act. That's a word salad there. So it established the Drug Enforcement Administration, the DEA. You've probably heard about that. To enforce the laws covering controlled substances and their distribution. So you've probably heard this about, controlling drugs and drug trafficking from Mexico, China, those places. The DEA is over that. It's part of the U.S. Justice Department. It's under the U.S. Justice Department. And what they did, the DEA actually created stair-step categories of controlled substances. We talked about this. I kind of alluded to it a little bit in the last PowerPoint about schedules 1 through 5 of the drugs. So it's Schedule 1, remember, is illegal. So they're drugs that cannot be prescribed. And that's something like heroin, LSD, marijuana federally is still a Schedule 1, although per state it varies obviously now. But in the past it's been a Schedule 1. And then you look at things like Schedule 2 drugs. Schedule 2 is the most addictive drug that you can be prescribed. It's things like Oxycontin, oxycodone, hydrocodone, pretty much any of the codones. Those highly addictive drugs are Schedule 2. They're highly regulated. There's a lot of rules around it. And we'll get into those rules because they are important. Schedule 3 gets a little bit looser as far as it is still a addictive. It's still in the addictive categories, right? But it's less addictive than a Schedule 2. So it's going to be like, I know one big one that they want you to know for Schedule 3 is like anabolic steroids. Those are like certain steroids that doctors will prescribe, or human growth hormone, things like that have to be regulated that people will take. And there's a couple more that are in the Schedule 3 category, but I can't remember. We'll go over specifics at another time. But Schedule 4 is like sleep drugs like Ambien, Lunesta, things like that. And even anti-anxiety drugs like benzodiazepines, things like Xanax, if you've heard of Xanax. So as it gets a little less addictive, the schedule gets higher up till a Schedule 5. Another thing to note is that actually Schedule 5 controlled drugs, some of them are you can even buy over the counter. And so I think we'll talk about that in another slide. Things like pseudoephedrine, that's one that you can buy it's behind the counter, so you have to go up to the pharmacy and buy it from them and give them your license and everything. But you can still buy it without a prescription. Some Schedule 5s you can. So that stair-step category is going to be important for you to know. On the test, they're going to want you to know, Schedule 1, 2, 3, 4, and 5, what those include and like the top drugs in each. And again, we'll go over them later at another time. Okay, so the Comprehensive Drug Abuse Prevention and Control Act also regulated the manufacturing, importation, possession, use, and distribution of medications and substances that have a potential for abuse. So if they're going in and out anywhere, it had to be regulated through the DEA, and those doctors that were giving out these drugs had to be regulated as well. Okay, so 1970 Poison Prevention Packaging Act required all medications to be placed in containers with child-proof caps or packaging. So nowadays, ever since then, when you go get a prescription, most of the prescriptions, except for a few, most of them will be in child-proof packaging, no matter what. Like they'll just give it to you, and then uh, that includes both OTC and legend drugs. Some exceptions include if your physician requests for a non-child-proof cap. Certain legend medications like nitroglycerin have to be in a certain bottle, and it has to be very quickly accessed. So they put them in non-child-proof bottles and packaging so that that person can get it quickly. Nitroglycerin is actually given for something called angina. It's a chest pain that someone gets. It's a rapid acting chest pain that happens super fast, and so they need that medication pretty quickly. And then hospital patients are patient requests. So if you're in the hospital, obviously you're not going to probably need a bottle of medication. They're just going to bring you the pill or put it in your IV. Patient requests, if you are a patient or a advocate for a patient, like if you're taking care of somebody and bringing them a medication, they might or you might request non-child-proof caps or packaging for that person as well. For example, my stepdad had a heart attack and a stroke a few years ago and doesn't have very good hand control now. So in order for him to have his autonomy, take his pills on his own, he has to have non-child-proof packaging and non-child-proof caps to be able to take his medicine on his own. So that's just an example. 1983 Orphan Drug Act. There was another one here, but I took it out, so forget the and here. But it eased restrictions and thus costs for development of new drugs for those with rare diseases affecting 1 in 200,000 people or more. So with this, the nice thing was, there was so much research being done at this time about, rare diseases that were affecting people. But it could take, years and years and years to get a drug on the market. I don't know if we ever watched the movie Lorenzo's Oil last year. I don't think we did. I can't remember. But that was like one example, was like the drug that they figured out helped. It was going to be years and years before it actually would come out. And so they had to find a way to get it. Oh, excuse me. They had to find a way to get it on the black market, basically, to save their son. So we might watch that this year. That'd be a good movie to watch. But anyway, so this helped ease the cost of developing that new drug for a specific rare disease, and also the timing, because they would be able to get it out sooner to the public. Okay, so this should be, I think this is 1997. Prescription Drug Marketing Act. Is this in the wrong place? It might be. Yeah, I think this is 1997. I'm gonna have to check and see, but this should be the 1997 Prescription Drug and Marketing Act. Helped to prevent counterfeit drugs and ingredients from entering the supply chain and limits diversion of pharmaceutical samples and prescription drugs. Maybe it was 1987. That might be more accurate. Sorry, guys. You don't need to actually know the year it came out. Like, they're not going to have you know that. But I put them in order. But clearly didn't do that good of a job. Okay, so 1990, Omnibus Budget Reconciliation Act, or Oprah 90. You probably heard of this last year in health science. It was enacted because of reimbursement regulations for people who are covered under Medicaid or Medicare. It requires pharmacists to counsel at the time of purchase all patients who receive new prescriptions. So that's like the biggest thing that this did for the pharmacy specifically, was required pharmacists to start counseling patients. Like, it was like a thing, like even today you have to be counseled. You can turn it down, which is what a lot of people do. Like, I remember the last time I got a prescription, they came over and said, because this is a new prescription, do you want counseling on it? And I said no. I kind of think that they're supposed to anyway, but I've never actually encountered that, so I don't know if they're not really doing what they're supposed to do because it says requires pharmacists to counsel. So at the time of purchase, all patients who receive a new prescription, so it has to be new to that patient. It's not like every prescription, but the first time that patient gets that medication. So I've never had that happen to me where a pharmacist talked to me about it, but I don't know. And then it also required pharmacists to keep records for all medications that Medicaid recipients use. So in 1996, Health Insurance Portability and Accountability Act, y'all probably heard of this also, HIPAA. The biggest thing, because it does talk about continuance of health insurance when you're changing employers, talks about protecting the patient's health information. That's all very important. But one of the biggest things that it affects in the pharmacy is that it requires new patients, like if it's a new person coming to this pharmacy, they have to sign a consent form. And so it's called the Acknowledgement of Notice of Privacy Practices. And so it's just an acknowledgement that a patient signs that you're basically saying, it's like one of those long, information sheets that no one ever reads. But basically it says, hey, you've got protected information. We're not going to give it out to other people. Sign this saying you saw, we told you that. And it also gives you the opportunity to grant that patient and their family members, if they want to have family members on there, the ability to see their information if they want to. So if they have, a spouse or something that they want to have access to their information, they can also sign, like they can put their spouse's name down. So this is something that they always have you the patient fill out the very first time they get a prescription with you. And then always shred computer printouts with PHI or protected health information. That's patient's protected health information. That was just a question on the test or on like a quiz that I had. It was like in the practice test. It was like, which of these is following the HIPAA guidelines? And it was like shredding computer printouts with PHI because it's basically like not allowing other people to see, private information from patients. So random thing I put on there. Okay, NPI numbers as it relates to HIPAA. So an NPI number is a national provider identifier number. The NPI is a unique identification number for covered healthcare providers. Pharmacists also require NPI numbers because they offer the MTM and other patient care services through that. NPI numbers are, and MTM is a medication therapy management, by the way. Medication therapy management. Yeah. NPI numbers are issued by the Centers for Medicaid and Medicare. That's a question on the big test. They always want to know where NPI numbers come from. So NPI numbers, if I can break it down for you easily, it's just basically anybody who is writing a prescription will have a special number, and it basically just follows them around. And any prescription that it's basically a doctor who can prescribe medications, but I think even now nurse practitioners can, and even some pharmacists can in some instances. So they can all have NPI numbers, and they're issued by the Centers for Medicaid and Medicare. That was kind of one of the main reasons, was they wanted to be able to track who was giving Medicaid and Medicare medications, like who was giving out those prescriptions. And so any doctor is going to have an NPI number. It's very important, and they want you to know who gives those out. It's the Centers for Medicaid and Medicare. It's really random, but that's what you need to know. Patient PHI and minimum necessary standard. The minimum necessary standard is that pharmacy staff may only disclose information about patients to other parties involved in the patient's care, such as prescribers, which is like a doctor, for verifying a prescription or health insurance, like with health insurance representatives, and for processing a claim covered by the cost of for covering the cost of medication. And then an adult patient's caregiver or child's parent or guardian may also have access to that PHI. And then another question they wanted you to know as it relates to this is how often must employers of pharmacy staff provide HIPAA training? And it's once a year. So once a year in your pharmacy, if you work in a pharmacy, you should be getting HIPAA training once a year. Okay, law enforcement purposes. So sometimes PHI may be disclosed to law enforcement officials, and these are just the reasons. So I don't even know if they put that in the test. I don't remember any questions like that, but it's kind of interesting. Okay, 2003 Medicare Modernization Act provides a drug discount card to those with low income who require assistance from a pharmacy company to obtain medications. 2005 was the Combat Meth Act. This addresses all areas of manufacture and sale of pseudoephedrine. So remember I talked about pseudoephedrine kind of at the beginning of this. It's an ingredient that makes methamphetamine or meth. If you've ever heard of meth, it's a drug, a street drug. So basically people would buy this over the counter, like in Sudafed, if you've ever heard of Sudafed, it's over the counter. You can buy it over the counter. And they would buy a ton of it and make meth. So there's strict guidelines to how much you can buy every day and every month. And so we'll go to that here in a minute. Only a licensed pharmacist or technician can sell, dispense, or distribute this drug. So that's important to note. And then all about pseudoephedrine. So it's a behind-the-counter drug called a BTC drug. So it's like an over-the-counter drug. You don't have to have a prescription. It's not a legend drug, right? But you have to buy it from the pharmacy itself. So you have to go up to the pharmacy and ask for it. I've actually bought it before. It really helped when I had really bad sinus headaches for a while. And it's a decongestant. So it's a drug that decongests your sinuses. It helps a lot with that. So it's a really powerful drug for people who have certain issues with, like, if you're sick with something, or for a while I just had like constant sinus problems, sinus pain, and it would cause me to have headaches, and so it like literally would be the only thing that got rid of the headache. So it's a powerful drug. It does work, but it's of course can be abused, and so that's why it's regulated. Important to note here, the law limits sales to 3.6 grams per day or 9 grams per month, which is a 30-day period. So this is important to remember, that it will always ask this question: how many grams a day can you buy of pseudoephedrine? It's 3.6 or 9 grams per month, whichever comes first. Well, not whichever comes first, because you can't buy 9 grams in a day, but you could buy 3 grams 3 days in a row and make it to 9 grams, and then that's all you get for that 30 days. The purchaser must buy at pharmacy counter and give a valid driver's license number or card to obtain the drug. Excuse me. And I think you actually have to have the valid driver's license with your picture ID on it. I don't think that they just take the number. So you actually have to have the card. 2010 Affordable Care Act, or Obamacare. 2 important technician-related components were electronic health records that came out in this, and medication therapy management was also something that came out in this that was important. And so for electronic health records, I'm kind of on the fence with them. There's a lot of talk about how they can be hacked, and so you have to be careful with that. Pretty much anything electronic now is it's just a concern, so there's that. But most places, not just the pharmacy, but most doctors' offices and things like that, are going to electronic health records because they're easier, but there are people out there that don't like it. So, and that is it, you guys. So I'm gonna go back here and look. Did we go over all of these? Let's see. I think I did. And this is 1987 Prescription Drug Marketing Act. Yeah, I just had the thing wrong there. So those are all the ones that you need to know. I probably will have you guys make note cards for this, so stay tuned on what we're going to do with these, with as far as the assignment that goes along with this. Okay, bye guys.